I want to introduce our speaker tonight. So we had a little giggle. I had an opportunity. You guys are in for a real treat because this doctor is not your typical run-of-the-mill doc that we're going to hear from. He's got a great sense of humor and incredible knowledge base that we are very privileged to have here. So Dr. Doug, see, there we go. I put your first name and your last name together.
It's all right.
Dr. Doug Egli is here with us, and he is coming to us from Santa Fe. He is the medical director of the Palliative Care Program at Christus St. Vincent. And so let's give him a warm Los Alamos welcome. Thank you.
Thank you very much.
Thanks for being here.
Thank you, Leanne. Very happy to be with you tonight. Thanks for inviting us up here. Thanks to the Los Alamos Council on Cancer, and Diane, thank you wherever you are for being so helpful getting us up here. My name is Doug Egli. I am the medical director for the Palliative Care Program. I'll tell you more about myself as we go along. Before we go any farther, anybody recognize that trail? You get a free business card. If not, that's the South Boundary Trail. It goes between Angel Fire and Taos, 26 miles. Fantastic hiking and mountain biking. So if you're ever up that way, try it. I know you have your own fantastic trails. I'll be at the Jemez Mountain Trail Run next month. So, okay, on we go. We're going to talk about palliative care. We're going to talk about what it is not. Does it even work? Is there any evidence that it works? And a few other little things along the way. You might figure out what this is about along the way. Is it just a kitchen utensil, or could it relate to this talk? When I tell people I'm a palliative care doctor, they go, oh yeah, I know what palliative care is. It's hospice, right? It's just hospice. Well, we're going to tell you how we're different from hospice, how we have some things in common, but palliative care is not hospice. It's been a discipline for about a decade now. And we have some similarities. We kind of came out of the hospice movement, but we have some definite differences. So, palliative care. It is not end-of-life care. Make my little thing work here. It's care focused on improving the quality of life for people with serious illness. That's basically all it is. I mean, I'll show you a much longer definition in a bit. Basically, we work with people who have serious illness, who have a limited life prognosis, and we're here to, using a variety of techniques and disciplines, improve their quality of life. That's as simple as it gets. So, life. I have some good news for you and bad news if you're into life. Life expectancy. Here's my pointer. You can see it's been pretty stable for quite a few thousand years. We're not going to, don't ask me how I got this data. I'm not going to tell you. I stole it off another speaker. The last 100 years has gone way up for a variety of reasons. Bad news. Death rate, still 100%. So even though we're living longer, we're living with chronic illness, we're having to figure out how to live. We're not dying of childbirth or infections at a young age. We're living with chronic illness a long time. And we're pretty good at managing chronic illness, but as we get to the end of chronic illness, there are quite a few symptoms that we can be of help with. And that's not only cancer, that could be heart disease, lung disease, kidney disease, neurologic disease. I'll show you a long list later. So let's just take a minute, and you can close your eyes if you want. I want you each to imagine how you would like the end of your life to be. Maybe not the most pleasant thought tonight, but let's, are you surrounded by your loved ones? Maybe you're at home, it's very peaceful. Maybe there's some nice music playing. Your pet might be with you. Maybe your clergy's with you. If you're like me, tropical island, beach, Mai Tai. That's for me. Okay, now, Have we all got a mental picture of where we'd want to be? Anybody choose this? No? Okay. 20% of seniors who go into the ICU will pass away in the ICU. How can we mitigate that? Mainly, it's done prior to coming into the hospital through conversation with your loved ones, which is the most important part, telling them what your wishes are should you become critically ill, telling your healthcare professionals. Those are very difficult talks to have. It's not fun. The palliative team can be of assistance in facilitating these talks, but it's really about letting your loved one know what your wishes are should you become critically ill. If you're in the ICU, the best way to work around a situation like this is to have a very high quality conversation with the intensive care physician. What does that mean? Straight up talk, no nonsense, no jargon. That physician should be asking about the patient's beliefs and wishes. Are they known? If they're not known, a lot of times what we do is ask the primary decision maker, well, if you were in that situation, what would you want? So, but if you've had the conversation, whether you have an advance directive or not, at least you have a good sense of what that person would want. So asking about beliefs and wishes, no nonsense. And then, like I said, if you don't know, then what would you want if you were there? Now let me say a couple things about CPR, because that always comes up if you come into the hospital. They want to ask you about your code status. CPR works awesome on TV. There's actually been a couple of studies where people got paid to watch medical TV shows and note how many codes went on in the season. They watched a few seasons. And this was done back in the 90s, and there was one done out at UCSF in the last couple of years. Codes work about 80% of the time. CPR works about 80% of the time when the person is resuscitated, they walk out of the hospital on TV. At the real hospital, if you're a healthy 25-year-old, you have about a 30% chance of walking out of the hospital without any debility. As you age and get chronic illness or debility, your chances go down. And so the senior citizen population, if you're pretty healthy, 20%. If you're disabled, it goes way down from there. So I think that, again, we don't talk about it. And when we start talking to families about it, they have a misconception of how well it works. But we do have an information sheet that we leave with the families, and we let them think about it. So that's CPR. Doesn't work so good. So medical care at the end of life is a poor value for patients my age and older. 25% of the Medicare dollars spent for a single patient is spent in the last year of their life. Now, that actually makes some sense in a way, because most of us are pretty healthy, and then maybe we get an illness like cancer, and then we start getting treatments, and we get more treatments, and we get scans, and we have lots of appointments. And so you're doing a lot more with the healthcare system. And so it makes some sense that we would spend more if you're basically healthy. But a lot of the care that people that are disabled, or maybe they're frail, they get a lot of care in the end of their life, the last year, and it's not always what they would want. When we start talking to them and say, what are your wishes, what are your hopes, they're experiencing care they don't want. and it's care that when you look back, it wasn't of benefit. And so what we're trying to do as a specialty is to kind of help patients decide what their wishes are, what we can do to facilitate those wishes, and to do things and not to do things that are harmful. So they get things they don't want, it's not of value, and they don't get the things that they would want and would be of value. Now, I want to tell you a little story. I've done this talk before, and I can do the story for either one of those hands up there. You might think it's going to be this one right here. It's pale, it's all wrinkled. It's got to be the person I'm going to tell you about. But tonight, we're going to talk about this person here. So, this happened probably 3 or 4 months ago. This was a middle-aged woman, came into the hospital, had actually been skiing up at the Los Alamos ski area, but wasn't a Los Alamos person, so don't try and figure out who it is. They were just skiing up there. And they had been feeling just out of sorts for a few weeks or months. And then they had finished a run, and they bent down to undo their boots, and they got really lightheaded and really almost passed out. So they came into the ER, and they started going over this patient. They noticed that she was kind of bloated, abdomen wasn't kind of tender, started doing some more tests, so they decided to admit the patient. More tests ensued over the next couple days. Stage 4 pancreatic cancer. Okay, the main symptoms were bloating and a little abdominal pain. So stage 4 means it's spread throughout the body. That is not curable. It could be contained if they have good response to therapy, but that is not something they're going to survive in the long run. Now, as I said, the patient really wasn't that symptomatic. And as you know, you get admitted, you get a hospitalist, and then they call an oncologist. And so those two physicians were already in on the situation, and then we got called in for goals of care, which means find out what the code status is. That's what that means at the hospital. But then just to offer support, because the hospitalist noticed that the wife was, or the husband was very, very upset. I'm getting my stories mixed up. So, of course, they both should be upset. This was a shock. They were skiing. All of a sudden, they're skiing. Now they've got stage 4 cancer to deal with. So, the oncologist says to me, oh, she's fine. She's not ready for you yet. Now, remember, we're just coming alongside, and we're just trying to improve the quality of life. We're not trying to change the care plan. We're just trying to support the patient and the family through the serious illness, whatever support might mean. That might just mean we just sit and listen. That might mean our social worker does some counseling. It might mean that we have to work on physical symptoms. It might mean they come to clinic and meet with our whole team for lots of different things that we'll talk to you about. But she's not ready yet. So, my question to you is, who's not ready? And not ready for what? Not ready for just hanging out and supporting the wife as they kind of figure out what they're going to do? Not ready for maybe working on comfort? Not ready for making sure that they're thinking down the road, that they do a little planning, that they have caregiving at home, that they are starting to get their paperwork in line, that they have whatever they need to deal with this serious illness. So who's not ready and what aren't they ready for? You don't have to answer that. We'll get back to that in a minute. Okay, so this is the, do I focus with the little gear shift? Is that the, should I do it? It looks kind of out of focus. So this is the official definition of palliative care from the Center of Palliative Care 2011, which is like the, that's the mecca of palliative care. So this is the real definition. Look at the red things here, if you just want to focus on that. But palliative care is specialized medical care. It's a specialty now. We're boarded. For serious illness, focused on providing patients with relief of symptoms, pain, stress, lots of stress. I'll keep reading it. Okay. Now I'm stressed. Nah, I can't. Hey, man. This is not the worst thing that's happened to me today. Okay. So there's a lot of stress for all family members, for the patient. So we're working on stress a lot. Improve the quality of life. We're just trying to make the day better, okay? For both the patient and the family. Palliative care is provided by doctors, nurses, social workers, clergy, massage therapists, acupuncture, I can go on. But lots of different disciplines. We're just providing an extra layer of support. We're not trying to take over. Palliative care is appropriate for any age, any stage of serious illness, and can be provided together with curative treatment. So we're not trying to take over. We're not a direct pipeline to hospice. We're just trying to make the day better. Who's not ready? Do I really need to say? Okay. Now, I'm not trying to make the oncologist the bad guy here. It's, actually, that oncologist is a fantastic doctor. But it just shows that many physicians aren't familiar with what we do. And some feel like we are. You're going to give them morphine, you're going to get the hospice sign up, and that's it. And you're going to get the code status changed. That's what we do. But actually, we do a lot more. And we're not trying to take over, I said. So they're not familiar with what we do. But they're getting better. They're worried that the patient's going to lose hope. Now, this is an issue because if they present what we do wrong, they do think like, oh, you're abandoning me. You're sending me over there to palliative clinic. That's the hospice pipeline. So we might want to call ourselves supportive care. Maybe I often say we're a supportive care clinic. But they don't want the patient to lose hope, and we'll talk about hope in a minute, but that's another concern. And this case, this wasn't the issue, but a lot of times, your doctor gets very attached to you, whether you believe it or not. And if you're with a doctor for years or decades, they form a relationship with you, and if things aren't going well, they feel bad. And, there's some grief on their end. So all these things could be going on, but the most, usually the biggest one that we run into is they're just not familiar with what we do. But it's getting much better, I'll have to say. So, yeah, not ready for what? We just want to make things better. We're not trying to take over. Okay, who can come to palliative care? Who's appropriate for palliative care? Who can come to our clinic? Well, here's a list. Advanced cardiovascular disease, advanced COPD, of course, cancer. A lot of cancer patients come. Now, this, when we first made this slide, metastatic cancer, and I think the oncologist would completely agree that stage 4 cancer patients should come. They should all come and see us. Even if they're really stable and they're responding well to their treatment, we can be of help. But I'm going to show you something in a bit that maybe earlier stages of certain cancers should come and see us. Dementia, stroke, cirrhosis, this really isn't a Santa Fe issue, but solid organ transplant patients awaiting transplant. Advanced neurologic disease, ALS, supranuclear palsy, all appropriate. Frail, elderly, multiple medical problems, just kind of dwindling, lots of arthritic problems, all of them are fine. We don't do chronic pain and stable and going to live a long time. We don't do that situation, or we'd be flooded. But if they have limited life prognosis And one of these kind of situations, we're happy to get involved. Okay, here's the other question that we often ask. Would you be surprised if that patient were to pass on in the next year? So a doctor will call me like a geriatrician and say, you know, I've got this person and they've got burned out rheumatoid arthritis, they've got a little COPD, they got some heart failure, they're bed to chair, they're wheelchair bound, you know, they're full care except for feeding, they're cachectic. Do you think they can come see me? And that's what I just say right there. You think they could pass on in the next year? Come on over. Okay, when should palliative care start? Now, this is what the hospital palliative care team deals with every day as we get called in on difficult situations where there wasn't any advanced care planning. And so we get a person, it might be a senior citizen, it could be a 30 or 40-year-old, but they have a serious illness they're not going to get over. And they're probably going to pass either in the hospital or shortly afterwards, and they want us to come in and start doing goals of care with the family. Usually the patient can't talk to us. Goals of care, what are the patient's wishes, what are you hoping for, how can we help? So that's what a lot of the inpatient looks like. But I'm going to suggest to you that a lot of our patients that come to clinic might look like that. And some of these people right here might have advanced illness. And so we want to see people that look like that because we have more time to work together as a group. And we don't have to be in crisis management. So we want to see them earlier. We want to see them when it's not a crisis. And we do. We're getting more early stage illness in, and it's fantastic. Now, what about palliative care at early stage cancer? I told you I was going to say something about this. And this may explain the whisk here pretty soon. So, there was a small retrospective study, just came out, Journal of Palliative Medicine this year, evaluating quality of life issues. There were significant, this is early stage breast cancer, stage 2. So it hasn't spread, regional. Looking at the symptom burden for these patients. Now these patients are felt to be very manageable, going to get through this, going to live a long time. But when they looked at the symptom burden for stage 2 and stage 4, took 2 groups, looked at them retrospectively, chart review, conclusion was that both groups had the same amount of symptoms, pain issues, emotional, practical, etc. So the conclusion from this small study, it's not very many, it's a couple hundred chart reviews, was that even more patients could benefit from palliative care. We're getting a few stage 2, stage 3 breast cancers. Now we get to the whisk. Does anybody know what that might be? If you're a physician, you can now answer. Okay, that's called a SAVI. That thing expands. That's going to be put into a cavity. You'll get to see the picture. So, the surgeon looks pretty happy. He puts that, okay, they'll do for a local excision on low-grade breast cancer. They don't do a mastectomy. They just do a local resection. Got this free cavity. They put that in there, and they expand it. And then they connect this up to radiation therapy. And so it delivers a high-intensity radiation right into the field where the surgery was done. Just started lately, I think. We just came to Santa Fe lately. But breaking news, that does not feel good. And it stays in there for about 10 days. And so it's in here. Sorry, sound guy. And the end is hanging out. And it's like going like this. So when they try and lay down at bed at night, it's like that. And if you try and turn on your side, no. And if you come this way, then it's going like that. So that is like a really bad week for that patient. It's a bad 10 days. So this is just I'm not saying it's not a bad, it's a bad thing for therapy. Obviously it's working because it's being done all over the place. And I can't comment on whether this is any better than, other radiation therapies, but I can tell you that it's very, very uncomfortable. And we have seen some low-grade breast cancers come into the clinic, breast cancer patients, and they have a lot of emotional issues developing cancer, as all cancer patients do. Surgical pain. When they start the hormonal blockade, they get some serious night sweats and hot flashes. And you cannot use estrogens because the tumors are usually, sensitive to the hormones. So we have to figure out other strategies for the hot flashes, and they can be horrendous. And so even though it's, only stage 2, you're going to get through it, there's a lot of issues physically and a lot emotionally. So there are things we can do. Now this comes out in about 7 days, I believe, but it's not a pleasant week. Now, let me just show you some different schematics, and I'll point out all the flaws and all these of how palliative care comes alongside traditional medical care. Now, this could be any kind of patient that had, this timeline could go on for 10 years, over a decade. And at the start of a serious illness, maybe it's not that serious, but they probably need some advanced care planning, get some advanced directives, maybe thinking down the road, make sure your living will's up to date. Talk to your family about what your wishes are so you become seriously ill. Okay, we don't do too much. Maybe even the primary care physician does all that if they have time. Something happens. They get an exacerbation of their illness. Maybe they get something, land in the hospital, and they get a lot of symptoms. So we have to go in and kind of help get through that illness, and they come back doing okay. Eventually, any serious illness, it's going to have the same kind of curve. You're going to have a period of kind of flat, and then you're going to start tilting downward where the disease starts to accelerate, right here. And then actually at the end, it really tilts down, straight down. Now, we are getting involved more with the patients as they're having more symptoms. So here, curative care is doing a little less, we're doing a little more. Towards the end of a serious illness, could be any serious illness, we're seeing the patient weekly, we're calling them 2 or 3 times a week, we're sending people over there, we're managing most of the situation. The primary care doctor is not doing too much. Now, my counseling friends were mad when they saw this slide because they want this bereavement part over in here. Because as the patient goes through a serious illness, as you may know, you start losing parts of your life. And so you aren't able to do what you used to do. I'm thinking of a patient who was a massive hiker. And when she couldn't hike anymore, that was really, really sad for her. And she has a lot of issues about that. She was very, very physically active. You can't drive anymore. In the book, Tuesdays with Maury, if you remember that book, there was a certain thing he said towards the start of the illness. He said, if I can't wipe a certain part of my body, that's it. He wanted to just go. But you're losing parts. He got to that part and he got through it. You're losing parts of your life, and loss causes grief. Lots of things. And so counseling can start over in here and should start over in here. Then my hospice friends were like, hey, you just gave us a tiny little sliver here. Well, the truth is, if this was a 10-year timeline, that's what it would look like, because the average stay in hospice is like 14 days. So. And then bereavement takes over after death. They're working with the family, and there's always a little tail on the grief that the counselors may have to work with for years. So that's one way to look at it. So we're just trying to help them live as best they can for as long as possible. Now, we tried to make another schematic to make my counseling friends happy. But here's the bereavement is into the active care spot. But I couldn't make all the little dips like the other slide. But here, bereavement is actually starting before they're passing because they're grieving. They're grieving the things they're losing. So counseling starts up here, and I made hospice a little wider so hospice would quit yelling at me. But I'm not as good on the computer. Now, here's another way to look at it. This is called the population approach. So, you know, we don't have too many palliative care doctors. So in Santa Fe, there's 3, and there's only 1 doing palliative care. The other 2 are doing hospice and something else. So northern New Mexico, you have 1. Albuquerque, you have a few more. Not too many south. So that we cannot do all of this by ourselves. I'm sorry. So what we need to do is figure out ways to do advanced care planning before they need to come and see somebody like me or our palliative care team. So primary care physicians, primary oncologists, primary cardiologists, they can start these conversations. You know, this could even be a nurse or somebody trained in the clinic to kind of start the conversations. You could hand a book. You could say, well, why don't you look at this and we'll talk about it next time. Primary palliative care, that would mean the primary physician, whoever that is, whether it's oncology or cardiology or pulmonary, they're doing the symptoms. You know, they're helping with the pain, they're helping with the constipation, they're helping with the anxiety, and we're not getting involved yet. Then things get a little worse, and they're not getting control of the symptoms, so then they call specialty palliative care. So that's what our clinic is. So we get involved, we start helping out, and then as that disease illness starts really accelerating, we pretty much are doing everything. So not that we want to, but it's just that that's the way it works out. So palliative care is the primary care team for the patient at the end. So that's a couple different ways to look at that. And I know that they all have flaws, and someday I'll have a better schematic for you. All right. Now, we're going to just talk a little bit about, is there any evidence that this even helps? So, this, I cannot read that slide very well, so I'm going to read it back here. This was a study that came out in 2010. This is lung cancer patients, non-small cell lung cancer patients, not very many, 150 patients. And what they did was, this was at Harvard, and they split them up in half. And so they said, okay, Group A, you're just going to get the standard oncologic care for your lung cancer. And everything else about the patients, the demographics were all the same. Their symptoms were all the same. They match them up. You know, they know how to do this. And then the other one, they said, okay, Group B, you're going to get palliative care. It's going to come in right away within the first couple weeks that you come to the oncologist. And then you're going to get this palliative care plus your regular oncologic care. Now, what does that mean they're going to get palliative care? Well, they don't really say what they did, but they said they had to go to palliative care clinic within a couple weeks of entering into the onc clinic, and then they left it up to the palliative care team and the patient to do what they thought was appropriate. So that it may have just been talking and supporting the patient and the family. There may not be, if it's, you know, early stage lung cancer, there may not be anything for us symptomatically to do. There could be, but it doesn't necessarily mean that. So anyway, they started this and they split them up and they followed them out. So let's see what happened. So, the palliative group had better quality of life. Okay, well, you would hope so because that's what we do all day. So you would hope that in some way we could make the quality of life better for these patients. If not, then probably shouldn't pay me. Their symptoms were better. It's not that the oncologist was bad at it, but we just do it all the time, and that's all we're focusing on. I'm not thinking about the chemo. I'm not thinking about what tests to do. I'm just trying to make them feel more comfortable. So that's what we're working on. Less depression. Now, was that because they handed out antidepressants? I don't really know. But I have a feeling it was that they knew that they had somebody that listened to them, that spent time with them, that was there to support them and their family. And sometimes that's all it takes. I mean, we had a patient yesterday who came into the clinic, and he was so angry, and every other word was an F-bomb, and he was so mad at everything. And we, I think it was, you didn't go in on that one, did you? I think it was just the nurse and I were in there for about 90 minutes. And so you don't get too many doctor appointments, 90-minute appointment, not many. So we worked on his symptoms, and we called him today, and he was like a changed man. He was so happy on the phone. And a lot of it was just that somebody cared, you know. Less likely to get invasive care at the end of life. Well, that has to do with what are their wishes, what are their goals, what is the prognosis. Does any of this really help if you're at the very end? So if we talk about it in a non-crisis way and have time to process it, they usually choose this. It doesn't mean they always choose it, but they tend not to. Now the next one. Okay, you figure that out. They lived longer. We've all got, there's some theories there in the paper, but I'm going to let you chew on that for a while. Why would they live longer? Better outcomes for loved ones. Okay, there was a recent study that showed that if the patient hadn't discussed their wishes with their family and they went into the ICU and they got intubated and they were sedated and it didn't look like they were going to survive, and the loved ones had to make the decisions about what to do, those loved ones have a lot of PTSD going down the road. So if we start discussing this ahead of time and everybody knows what it's all out there and the family knows what their wishes are and there's no secrets, we've pulled back all the curtains, it'll be better for the family. And so a lot of times what I'll say is, you know, this is really hard for your family. They'll say, oh, you know, I'll be out. I don't care. I'll just let my wife decide. Well, that's really hard. It's really hard to decide, okay, today's the day we're taking the tube out. It's really, really hard. So if we can talk about it ahead of time, it's just better for everybody, especially for the family. Okay, so higher satisfaction. They were just more satisfied with their care in general and satisfied with their life. So their quality of life scores were better. So that was, now I know it's very small, not a big population study, but there's some evidence that this might be helpful. Now here's the one, are there any hospital administrators? No? Save money. So they tend not to go into the ICU as much because they had the discussions about what their wishes are. They tend to stay home when they're getting towards the end of their illness. They tend to choose less invasive treatments. So money is saved for the system. So there's a little bit how it works. Does it work? Now let's look at an outpatient study. Outpatient, this was done at the University of California, San Francisco Cancer Center. I'm sure you've heard of them. This is another one. It's a little bit bigger study, 920 patients who died with advanced cancer over about 30 months. Palliative care, now this is looking at just retrospectively what was done with the patients. They have a big palliative care program there. Dr. Pantalat was here with us in the winter. I don't know if anybody came and listened to him. He's fantastic if you ever get a chance. They have a very strong palliative care program. But not too many cancer patients went to palliative care clinic. 10% went 3 months before the end of their life. I don't know. I want to do that study at our cancer center now that we're up and running. So, quality assurance project. I'm hoping we're better than this. We're trying very hard to be very active with our cancer center. 10% were seen 3 months before the end of their life. 22% got some palliative care, which is pretty normal. Wait till it's crisis. The rest didn't get anything. They just got the standard oncologic care. Most of the early palliative care was in clinic, which is where it should be. It should be in the clinic. Much nicer. We have nice rooms. Spend a lot of time. Very relaxed. Okay, so what did they find out? The palliative care panels, lower ER visits and ICU stays for the last 30 days of life. Fewer inpatient deaths. So again, we're just trying to figure out what they want, what their wishes are, and kind of explain things. Is it really helpful if you're that sick to go to the hospital? Now, the outpatient costs were higher because they're coming to see the palliative care clinic more, in addition to their cancer appointments, which, if you have any experience with cancer care, you know they're going to cancer clinic all the time for chemo, hydration, blood tests, scans, doctor's appointments. So then you add us in on top of that. So outpatient costs are up a bit, but they stay out of the hospital. So the total savings, if you're interested in that, was $5,000 per patient. So it's good for the system in general. More important, the patients got what they wanted. So it reduces, okay, this is the inpatient stay. I'm sorry, I had another slide in there. So inpatient palliative care. So this is where we're coming in. They're already pretty ill. They're in the hospital. Now, if we are asked to come and see the patient within 2 days of admission, we can reduce length of stay and reduce cost. A lot of times we get called day 17, and we're so far down the road, and so many things are happening. So we can't have a big impact on cost, but sometimes we can figure out what their wishes are. But if we have a chance to have a good conversation with the patient and the family, and we can kind of build a relationship, and we're not in crisis management, we can reduce readmission rates. Why is that? We figure out what they want, we set them up what they need, whether that's home programs coming to our clinic, we track them, and they usually don't bounce back. So we can impact even inpatients, but they need to call us. So the new models coming out of medicine have to do with value. Value-based medicine, I believe is what it's called. So that equation is quality over cost. So if you're into hospital administration, I'm sure you've heard about that. Okay, quality is driven by satisfaction increasing in lifespan, decreased symptoms, better quality of life scores. Let's see if I have it. Cost, of course, is just cost. So we've already shown you several little studies. We can improve the quality of life of the patient, and we can reduce cost. There are not that many things in medicine that reduces cost and improves quality scores. I'm just going to tell you. If you don't believe me, ask somebody that's somebody else. But we actually can do this if they'll call us. So we increase quality, lower cost for most serious little people. You would think they would like us. Okay, now we're going to go back to our little case. She will lose hope. That's a funny word there, that hope. Whose hope and what are they hoping for? If you have a terminal illness that you can't survive, what should you be hoping for? What's the doctor hoping for? It's just a curious word there. So, hope. Maybe you change the focus of hope. So maybe you're not hoping for a miracle or a cure. Maybe you're hoping for healing. That's another way we could spend another 10 minutes on. Healing doesn't always mean you're cured of your illness, but maybe you can get some healing in different ways when there is no cure. For comfort in the face of a serious illness with just no fun, and it sucks. And you're suffering because you're going to leave and your family suffering because you're going to leave. But maybe you can have some good days, and maybe you can find some comfort. And hoping for what can be each day despite what can't be. So that would be kind of like focusing on what you can do, not what you can't. So those are some things we can hope for. We can't hope for a cure on a lot of our patients. So, there's nothing more we can do. Another phrase that makes me cringe. If you are a healthcare provider, please don't say that. Please make a pledge. If you don't remember anything else tonight, please remember that. Don't say that. I've said it. There's nothing more we can do. Well, it's simply not true. Okay, some things may not work, but there's a lot of things that I've been telling you about that we can do for patients with serious illness. We can make sure that they're calm and comfortable and that the day that they have is as good as it can be. And if I come and tell you, you know, Mr. Smith, there's nothing more I can do for you. Why don't you just sign up for hospice? What do you feel like? Let's say I've been taking care of you 10 years. You feel like I've abandoned you. And so we don't want that. We just want to change the focus of caregiving, okay? We are changing out of a curative focus, or maybe we're coming alongside of the curative while they're still working on it. But we're changing the focus to not focus on whether we can cure it or not, but can we have a quality day, a quality week, a quality month, and that we're going to hang in there with you. Now, the patient I was telling you about earlier that was so angry, I think he was really surprised that we called him back today. I was sitting there with the nurse. He's like, oh, it's you guys. You called me. I think that they just need to know that we're there for them. And we're really going to hang in there with them. And it's a hard problem. You know, it's hard problems. And I don't have all the answers every day, but we're going to hang in there with them. So I think that that's really why that guy was so happy. But we did fix some of his symptoms. So here's two phrases. If you are a healthcare professional, let's all not say this. Now, we've got it taped up in our office. There's nothing more we can do. Okay, there should be a little thing here. Don't say that. All right. What could you say instead? You could say what I told you. We're going to change the focus of trying to cure or fix the problem. Let's say you have a very, very bad heart, and I cannot make the heart pump any better, any stronger. And I wish I could. But I can make you comfortable, and I'm not going to just knock you out. I'm going to make you comfortable. We're going to work for quality days, but I wish I really could fix that heart. I cannot do that. What would you like us to do? Everything possible. Okay, you're in the ER. You're with your parent. Mr. Egli, would you like us to do everything possible for your dad? Okay, if you're not medical, and the doctor comes in and says that, isn't that kind of ridiculous? Well, let's see, my dad didn't go to my Little League games. He didn't get me that bow and arrow set. I didn't get him a mini bike. Okay, just do 50% for him. I only want 50% because he really pissed me off when I was 13. No, it's a ridiculous question. Don't say it. What were you hoping for when you came here today? How can we help? What are you hoping for? If you say, do you want us to do everything? You may not, don't even ask it. They're going to say yes. Of course they're going to say that. It's crazy. All right. So remember those two things. If you have to zone out now, it's okay. All right, now I'm going to talk a little bit about what we do. I've already told you some of the things, but I've got a big list here so you can look at it. So I spend a lot of my day working on symptoms. And so pain is the big one for lots of patients. It doesn't matter if they're cancer or not. Lots of people have pain that's hard to control. And we have a few little tricks and things up in our bag of tricks that maybe some of the other doctors don't want to do or they haven't done. And so that's why I get paid to do that stuff. And some of the other symptoms we're working on a lot of anxiety issues. It's not always medication. I'll get to that in a minute. Constipation. If you're taking narcotics, you're going to have constipation. It's not an allergy. It's a side effect. And you're going to have a bowel program if you're on narcotics. So, yes, patient, I got called 5 minutes before we get in the car. The oncologist called me and said, Mrs. So-and-so's in the hospital. She hasn't pooped in 14 days and she's got a functional bowel obstruction. Can you come and help me? I'll be there after the lecture. So, constipation, it's a big deal. Depression, we can help without giving medication. Just by being a presence, by listening, by letting them know that we're there for them, by fixing some of these other symptoms, their mood will improve. We have counseling. We have lots of different counseling mechanisms. It doesn't have to be an antidepressant. Social work. So we have social workers both at the clinic and the hospital. And they're working on counseling, on obtaining services, and just jack of all trades. If I don't know how to get something done, I talk to social workers. Nursing support, we have nurses both in the clinic and the outpatient service. And they're coordinating care, making follow-up phone calls, reminding me all the things I didn't do, seeing the patients I couldn't get to on the inpatient service, and so we can't make it without them. Spiritual care is actually a different department at St. Vincent's, but they're coming alongside of us because there's a lot of existential things. It doesn't matter what your persuasion, and we have all kinds of spiritual care at St. Vincent's, not just Catholics, because we have all kinds of people, and we have all kinds of belief systems, and we have people with no belief systems, but they want to talk to spiritual care. And so we offer that, and we offer that in the clinic. Advanced care planning. You know, when somebody comes in with a new cancer diagnosis and we're lucky enough to talk to them at the start of the illness, I'll say, there was a patient this week. He lives by himself. His sister lives 20 miles out of town. He has a limited circle of friends in town. And he's got something serious. He's probably going to get pretty sick, either from his therapy or from his illness. And so, hey, who's going to help you on those days you can't get out of bed? Who's going to go drive you to your doctor's appointment? Who's going to go get your medication? Nothing. So, if we can get in ahead of time and talk about it, we can start making a plan. It's not that it's rocket science. There are services. That's why we have social workers. Talk about it. Goals of care. As they learn more about their illness, as they do treatments, their goals probably going to shift. It happens every time. But just kind of reviewing what their goal is, what their wishes are. Are we meeting their goals? Integrative medicine, we have a fantastic integrative medicine program that comes alongside of us. It's part of us, and they work in the hospital, and particularly in the clinic. So we have acupuncture therapy. How could that work? A lot of patients get peripheral neuropathy from their chemo. The ends of their fingers and toes tingle because of the effects of the chemotherapy. Now, I can give them pills, but acupuncture very, very effective. Do I have any data? No. There might be somewhere I haven't really had time to look, but I can tell you that it works, and a lot of people don't want to swallow pills. And so they come for acupuncture, and it helps them. And the sooner they come, as soon as they get the tingling, that's when they want to see them. So acupuncture, very helpful for that. It's very helpful for different kinds of aches and pains. They can work on a lot of the symptoms I work on. They can work on mood. A lot of patients in the Santa Fe area are on a zillion herbs, and they need kind of consultation about how that's going to interact with their therapies. and I have no idea. So we have a doctor of Oriental medicine, and he takes all that. I have no idea how that stuff works. We have massage therapy. Our massage therapist has received special training to work with cancer patients. And a lot of the things he can do, it's not like massage envy. And it's not like massage light, you know. Okay, they got cancer, just going to barely touch them. They can work on a lot of the things that I'm working on. Peripheral neuropathy, tension, anxiety, mood. Now, there are some reimbursement issues. Our program director, Amy, will vouch for that. But it's very effective, and who doesn't want a massage? I mean, honestly, you know, if you're feeling bad, fantastic. But the reimbursement issue is a problem, and we acknowledge that. But there's not that many palliative programs that have all this coming alongside, so we're really lucky to have all this. Now we have, for those patients that are higher performance status, we have yoga, qigong, and tai chi. The instructors are tailoring these programs for patients with serious illness. You do not have to be 25 years old and a triathlete. You can do yoga in your chair. We have individual meditation, group meditation, guided imagery, relaxation technique that can help with anxiety, depression, insomnia, and pain. Hypnotherapy, kind of on a continuum from there. Thinking of a lady from Taos, had moderate pain symptoms on a moderate amount of narcotic, started doing guided imagery, got off her narcotic. So guided imagery, hypnotherapy, good for relaxation, insomnia, lots of different things. Best part, it's free. It's helpful, it's relaxing, and it's free. Come on. Art therapy. I don't know if we have many people participating, but we do have art therapy. Do we? Not right now. We have it available. Oh, scratch that. We did have it. Okay. Now, what do we do when we talk to patients? At the hospital, this is the hard part. We sit down. You've been to the hospital lately? It's hard to sit down. It's hard to find a chair. There's always stuff on the chairs. There's no chair. You got to go find a chair. There's been studies on this that patients perceive, if the physician sits down, they perceive the physician was there longer. There was one out of UCSF where they sent the doctor in. Dr. A sat down. And they pulled him out. They beeped him or something. They pulled him out at the same time as Dr. B, who didn't sit down. And so they did this a bunch of times. In the room, the same time, Dr. A sitting down, Dr. B standing up. And they went back to the patients. How long was your doctor in here? The sitting down group, the doctor was there longer. Now, there's actually another study where they were timing the physicians. And the physicians, they didn't pull them out or anything, but they had them sit or stand. The ones that sat down stayed longer. So there is some perception and some reality that they sit down, they stay longer, and if they would quit looking at their darn phone, then we'd be really good. But you sit down, you listen. That's a really hard thing today. Average, if you're in a clinic and seeing your regular doctor, what do you think is the average time between the time he or she asks you a question and the time they interrupt you? Got a guess? Oh, yeah. I'll take one more guess. 18 seconds. And my friend who's primary care, you go, well, I got that beat. So, yeah, we don't listen. Now, in fairness to primary care physicians, I was one for a long time. You've got a very limited time to be with them. This might be the problem list. This might be the medication list. And so you have got to try and work your way through that as best you can. So sometimes you really have to focus the visit, and you can't just kind of let it flow. But 18 seconds, man, I mean, that's pretty rough. So we're just trying to ask open-ended questions, not be in a hurry, and kind of let it flow and see where it goes. I'm trying to guide the visit. Then we talk. Then I start contributing, or I just ask more open-ended questions, just let them kind of take over. So like I said, you know, we were with a new patient yesterday, 90 minutes. You don't get that too often. What are we trying to figure out? It's probably what I've been telling you the whole time. We're trying to figure out what they want, where they're coming from, what their values are. We're just listening and not trying to project what we think they should choose. We just want to find out what they know and what they wish would happen. We try not to use doctor speak. And if we do, I hope somebody slaps me or something. But we want to use no jargon. We want to use just regular speech, regular words. Now, this thing about discussing prognosis. There's quite a few studies in the medical literature that patients really want to talk about that. And doctors don't, because they don't want the patient to lose hope. But guess what? Has anybody heard of Google yet? They're Googling. As soon as you tell them anything, you probably Googled me, figure out who I was. You find a bunch of swim meet stuff. They're Googling about their illness. So when they come in to see me, you know, I'll say, what has your doctor said? I get this. Been Googling? You want to talk about it? Not really. Looks pretty bad. So then you've got somebody looking at some unknown website with not much background and not much kind of, you know, interpretation of what they're looking at. And so then what do? They start putting their own spin on what they read. And then they go completely down the wrong trail. They might be completely off on what their prognosis is. Might be really good. Might be bad, I don't know. But the thing is that they need information that's unfiltered and it's not from Reddit or AOL or HuffPost. And they want to talk about it. So I try not to step on any toes, but I will open up the can of worms and talk about it. And then I tell them, go back to your cancer doctor or your heart doctor or your pulmonary doctor and straight up ask them, what is your prognosis? And see what happens. Okay. When we talk to patients with serious illness, what happens? What does it do for the patient? It promotes a sense that they're in control, which I always try to tell them. Okay, you are in control of this. If you get the right information, you get enough information, you can decide what you want. Now, doctors, we like to be paternal. We like to be in control, just like your auto mechanic. I just go there. It's all, you know, la, 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 la. Okay, just do it. But I'm trying to cut through that and help them get the information they need to make decisions in line with their wishes. Patients want to talk about this stuff. Not all doctors do. This is what increases satisfaction scores and patient satisfaction because they're feeling listened to, just like the guy from yesterday. Yeah, we did a few things with medicine. We didn't do that much. But I think that he knew that he had a group of people there that would listen to him and that were there for him. As I said, if you don't get the right information, maybe you get a little bit of it, you just head off with that on your own little journey, and you're going to end up somewhere that's probably not where you really should be. So they get information, they make inferences, and they get completely down the wrong path. So we're just trying to promote information. Talking about values of goals and values of goals. Okay. This is another thing we have taped up in our office that the nurses try to use when they're talking to new patients. And it's kind of interesting when you do this to see what happens. So when you look in the future, what are you hoping for? Now, if you have accurate information about your illness, maybe you could kind of think about your future. If you are in 100 out of 10 pain, you're not thinking about your future. But if we can get them calm and comfortable, they can start processing, and they get the right information, they can start processing this information. What do you think? What are you hoping for as you look out to the future? You'll get a lot of interesting answers. Some have definite wishes that they want to accomplish. They want to get to a certain date, they want to see a certain thing, they want to do a certain thing, they've got a bucket list. Others have been suffering so much, they're just like the next 5 minutes. When you think about what lies ahead, what worries you most? Now, yesterday or the day before, I had a couple in, and the patient's pretty quiet. The wife is a nurse, and she's completely focused on the next thing, the next test, got to get to the chemo appointment, got to do this, got to get the medicine. So I asked her this question, and all the tears started coming. And it's the first time that she cried. So you can get to some stuff with these questions. And then you can do some work. And then I can bring in our counseling people and say, hey, got some work to do here. So if you're going to talk to people, those are nice questions. They're open-ended. Okay, there's a couple studies out. What are patients looking for when they have serious illness? They want to be comfortable. So that's what we're working on all the time. Every day we're just working on that. As I said, no BS, no jargon, straight up what's going on, no doctor talk. And they want support. They want to know you're going to be with them, whether they're having a good day or bad, that you're there for them for the whole thing. They want to feel supported. All right. Now, you would think that if I took a survey of the most important issues for patients that have a terminal illness, maybe they have 12 months to live, 2 years, I don't know. Live as long as possible. You would think that would be the top thing they want. But no, it was the bottom thing. Now, it wasn't there was zero wanting that. Of course, you want to live as long as you can with as much quality as you can. That's what most people want. But what was the top thing? Well, all these actually, these four were all pretty close. I think the P scores were pretty close. But anyway, making sure that I don't completely bankrupt my family. Number one cause of bankruptcy in America, medical bills. Being comfortable and without pain. Now, this is a big thing, is that when you start talking to them and they want to know, hey, doc, how's this going to go? And I say, well, what do you mean by that? You know, how's it going to go? You know, how am I going to go? Am I going to die gasping for breath and pain? And I go, well, not if I can help it. So we have to have a lot of chat about that. We have to chat about it quite a bit, and we have to work at it, and we have to know, they have to know that we're there with them. And that if we get a hospice team involved, that team's going to know what they're doing. But they're not going to die in pain if we can help it. And we're really on end-of-life care, it's over 95%. And honestly, we haven't done a survey on our patients, but that doesn't happen too much anymore. Being at peace spiritually. It doesn't necessarily have anything to do with your worldview or your religion or anything else. It just means that you are okay with what's going on, no matter what your slant. Now look at this one. They didn't want to talk about the goals of care and the code status and filling out an advance directive, but they don't want their family to be burdened by making the decisions if they're unresponsive or critically ill and can't talk to their physicians. But then in the clinic, we're talking to them about this, and they don't want to do it. And it usually takes us probably 3 or 4 weeks to get through that document. But that's actually something that bugs patients with serious illness. And then we talked about this, living as long as possible. I get that. Okay, we're coming to the end. So, what can we say about this whole thing? Hopefully you learned something tonight. You learned about a new medical device, and you learned to say a couple of key phrases or not to say a couple of key phrases. So, you hopefully know that palliative care can improve the quality of life for patients with serious illness. We need more palliative care professionals, whether they be doctors, nurses, social workers, counselors. And so we need people in the primary care clinics to be screening. A lot of doctors don't even know what we do at the primary care level, and we're going to start working on that in Santa Fe and letting them know where. We just talked to a doctor Tuesday, I think. Was it Tuesday? She didn't even know we're there. And she's like one of the main primary care people in Santa Fe. So helping us screen the population. All the doctors on the primary care and the ground level need to know some of the basic skills of keeping people comfortable and being comfortable with narcotics and other pain medicine, all kinds of things. Then the palliative care services needs to move out of the clinics into the other offices, embed in satellite offices, go to homes, make home visits, because, you know, the patients, we get probably a 30% no-show rate because they feel crummy and they don't want to come into clinic. Or they live in Taos and they feel crummy and they don't want to come down here just for me to talk to them. So we talk on the phone. But we need to move out of the clinic at some point. And training for palliative care specialists, there's not many palliative care trained physicians. The fellowship programs, I think UNM puts out 1 or 2 a year. And even UCSF, which is a huge deal, they're putting out like 4 fellows a year. So really, not that many doctors. As I said, we don't have too many. And the 3 of us in Santa Fe were grandfathered. We didn't do a fellowship program. So I'm going to give you a little quiz here. I stole this from Dr. Pantalat, and then we're going to quit. And if there's any questions, I'm happy to answer anything. So think of this. You don't have to answer now, but think of it. Who are the 5 richest people in the world? Who won the last 3 Heisman trophies? 10 people who won a Nobel Prize. Or they might be here, I don't know. It's Alamos. Name the best actor and actress from last year, Academy Awards. Who won the World Series the last 5 years? Okay, how'd you do? When I got this, I don't even think I got 1. All right, let's try another quiz. Name 1 teacher that you had along in your life that helped you where you are today. Or maybe 1 teacher you hated that made you come where you're at. Name 1 friend who's helped you in difficult times. Name 2 people who taught you something worthwhile. Think of a person who made you feel appreciated. Name 1 hero in your life. Do any better? Why is that? Because it's not all the awards and the money that we remember at the end of the day. It's for people who cared about us. That is the end of the talk. This is our clinic. The cancer care clinic is right there if you know where it is. If you know where Albert's and Zia, there's a Walgreens. We're right behind there. That's the cancer care clinic. We're here in an unnamed building. We have a little sandwich sign, but We're in there. We have a very nice clinic. I didn't bring any clinic pictures, but we're right there. So if you come out the Cancer Care Clinic, we're right there. I'd like to introduce Amy Fredericks, who's our program director. Do you want to say anything? No?
Other than we have brochures outside about the services that we offer, so if you have other questions that maybe you don't want to ask today, but want to follow up with us, please do.
Yes, I'd like to thank you again for listening to me, or at least looking like you were listening to me. And I'm happy to entertain any questions. If not, you can email me at any time. There's cards here with my email. And if something comes up down the road and you're not sure, you can email us and talk to us at any time. Yes? Oh, thank you. Go ahead. The question was, can you make a direct referral to palliative medicine clinic, or does you have to come through a physician? We generally like you to come through a physician because, as I said, we have a few restrictions right now. We can't do chronic stable medical problems. We can't do like chronic back pain or fibromyalgia and stuff. So we want to have your regular doctor, whether that be specialist or primary care kind of screen situation. But if they're not sure, they can call us, and we're happy to talk about it. And like I say, if there's any question that this is a serious illness with a limited prognosis, come on over.
A lot of times patients will come and make an appointment because they've seen a couple different specialists or received second opinions, and they just want a home to go to process all the information they've gathered. And so we've done that before as well, so that's an option.
Okay, I guess we have questions down here.
We do have some questions. Thank you, everyone, and thank you for an amazing presentation. You know, one thing that really struck me as you were sharing was the need to raise awareness for this type of care.
Right.
And because when we do that, then we can more easily accept the situation that we're in.
Right.
And that we're talking to our friends and loved ones about, and then we can make conscious choices.
Right.
But without those things, you just did a beautiful job. Didn't he just do a great job? So thanks again. Yeah.
Thank you.
Excellent. Excellent. So several questions actually came in regarding insurance.
Ha ha.
It's a big surprise right there,
Yeah.
right? So what can you share about, are most insurance agencies covering palliative care? Yeah, and so, they're asking about Medicare, Medicaid. We'll start there.
Okay, Amy's got that one.
So we do bill Medicare for the services, and they do pay us a little bit for it. So yes, Medicare, we do accept Medicare, and they do pay for the service. It's different than hospice, where they bundle the charges, and so hospice bills and then provides all the services under what they receive from Medicare. We bill the same as if you were going to go to your primary care physician and see them. So yes, it is reimbursing right now. There's some legislation that's happening that's looking at having specific codes that hopefully will reimburse us at a higher rate and actually pay us for what we're doing, but we are getting paid some by Medicare. Private insurance generally follows the rule of Medicare, so some of insurance is also paying for the palliative care. Now for the integrative medicine pieces that he was talking about, so the acupuncture, massage, guided imagery, those sorts of things, Medicare does not pay for those. So we do case-by-case basis and talk about what your needs are and how we can help you get the services that you need. Was that it about insurance?
There's some foundation funds available at times, right, on
Right.
some of those?
Yeah.
And then some of those, like counseling, guided imagery, may not be a charge.
Right. So what we've chosen to do at our clinic is handle it internally, meaning if you come to see Dr. Egli and he recommends that you get guided imagery or counseling, that's just included in your visit with him, that those services are ancillary services, much like if you were in the hospital and needed those services. So that's how we've been working it out so far. So is there another insurance?
And the exercise classes are $20 for 6 sessions a month, right? Isn't that it?
So the exercise classes, we actually, because our foundation received a grant for people living with cancer, the classes are half price. So one of the benefits, right, of having cancer is you have half price exercise class. But so instead of $10, it's a $5 per class, or we have packages of 6 classes for $50.
Oh, I thought it was
But
good.
half
Sorry.
price for the folks that are helped through our foundation. So very reasonable. And the classes are nice because it's not like going to the gym or body. We've got people that come in with their oxygen tanks or that have to sit to do the movement classes, but know that any kind of movement that they can do is going to help their overall well-being. So.
Right.
And then there was a question about the cost. And so, I mean, each one of these services has a different cost associated. So, I mean, I'm happy to talk one-on-one about that if someone has a specific question about which service. Again, it depends. For Dr. Egli, if you don't have insurance at all, we have a sliding scale or a discount for that. And it depends on if it's a 90-minute visit, which can be costly, or a 10-minute visit or a phone call to manage medications over the phone. So I hate to give out all the prices, but would be happy to talk with anyone one-on-one about that.
The question is, what percentage does Medicare deny the claim?
Yeah, and so as long as we use the right codes and give them everything that they need, which it can take months sometimes to make that happen, but they're not denying for palliative care. Now they will not pay for acupuncture, and so that's not a matter of denying. It's just a non-covered benefit or non-covered service under Medicare, and so we do offer a 40% discount for that as well for private pay.
It's all about the coding, if you didn't know.
Ask it again.
Copay.
Okay, so if Medicare will pay 80%, just like any other visit, so that 20% is left over for your responsibility, so you either have a supplement or a secondary, or you pay the 20%, correct?
Okay. We'll do the cards first, then we'll get to the
Perfect. Then
hands.
I can run the mic to you so you can make sure you get recorded on
Okay.
the taping with FACP. So here's a question. I'm just going to read it verbatim, all right? That's the way I like to roll. How good are doctors at making a terminal diagnosis? How often does a patient recover from a terminal diagnosis or significantly outlive the prediction?
Okay, that's a good one. Well, our crystal balls are all busted, and they're in the closet. So, especially on non-cancer, we're horrible, unless they're right at the end. So we're making our best guess, and so are all the other doctors. And we're basing it on, kind of the slope of illness, slope of decline, performance status, a lot of different things. But we're not very good on non-cancer. Cancer, we're a little better. How often do patients outlive their prognosis? Well, if they get comfortable and they get their wishes, I just showed you in a study that they outlive the projections. And so it happens more and more that they're outliving the projection. We're very bad at this 3 months thing or whatever, You always hear that. It gave me 3 months to live, and here it's a year later. But we pretty much know which cancers aren't fixable. And so we know that the illness will eventually take that patient's life, but we're very bad on the prognosis till we get right down into it when they're very ill. So I hope that answers that.
Okay, great. And here's another question. Will palliative care actually extend life? And I know you addressed that some. Maybe in answer to that question, you could share a story.
Well, I think that it can. Now, I've showed you some evidence. If you are completely miserable from your chemo and you're vomiting, and you're hurting, and you can't get to your chemo treatment, and the chemo would be helpful, but you don't take it because you're miserable. But if I come along or another palliative team comes along and I can fix those symptoms and you can complete your treatment and you don't feel miserable through it, then you could live longer. And also patients, it's been shown that patients that have less depression and anxiety and higher quality of life scores will live longer. So again, that's what we're doing. So can we extend life? I believe we can. And there are, remember I showed you that study where I said they live longer and I told you figure it out? Well, actually the comments were, number one, if we fix the symptoms associated with therapy, they're more likely to complete the therapy. And also they have lower depression scores and higher quality of life, which has been shown to extend patients' lives with serious illness, not just cancer. So again, yes, we can impact the length of life.
Excellent answer. Is there any other questions from the audience? Okay, if you could hold on and wait for the mic, that would be great. I'll run it to you.
I just wanted to ask, are all the services at the clinic? Because sometimes if people are quite ill, they don't want to leave home.
Yes, we can't visit yet because we don't have staffing. And that's what I was talking about. We need to move out because you're exactly right. And that's why we have a 30% no-show rate, because they just don't feel like coming in because they're sick. And we try and do things over the phone, but we want to get to this place where we can make home visits. Now, there's a couple of palliative teams in Albuquerque that are doing that. We're just not there yet. But like Albuquerque has 2 teams making home visits. So.
My question is, where is the difference to hospice?
Okay, the difference from hospice. Okay, we've got to go over this again. Now, hospice, when you go on to hospice care, yes, you have what's felt to be a terminal illness, and 2 doctors feel like you probably have a prognosis of less than 6 months. But I just told you we're terrible at predicting. Now, hospice does a lot of the things we're doing. They work on comfort, they work on staying calm, they work on constipation, they have counseling. They visit the house, so that's pretty great. They provide all your comfort medications, they provide medical equipment, it's all free. What do you give up on hospice? Now, let's say you're a cancer patient. You're giving up active cancer therapy, no more chemo, radiation, hormonal therapy, man or woman. You're giving up active therapy. No more testing, no more blood tests, no more scans. Now, for some patients, that's like, hey, cool. But you are giving that up, okay? No more of that. Generally, they want to keep you out of the hospital. So, now, that's not to say you can't go into the hospital, but they are trying to keep you out of the hospital. We're just coming alongside what you're doing and just trying to make things better, but we don't have any restrictions on what you do. You keep going to your doctors, you do what tests you want to do, you do what therapy you want to do, whether it's cancer, pulmonary, dialysis, etc. Keep on doing it. We're just trying to make it a little better for you. Does that answer your question? The hospice is coming to you, and the hospice, you're just focusing only on staying comfortable. No more active or curative therapy. Our team, no, we can't go to your house yet, but maybe if I come back in 2 years, we will be. We're focusing on staying calm and comfortable, but I'm not telling you can't go get a CAT scan if you and your doctor decide you need it. I'm not telling you can't have radiation. So that's the difference. It is. There we go.
Does the palliative care team see those cancer patients who decide right at the time of their diagnosis that they don't want any treatment at all?
Absolutely.
So you will see them as well?
Absolutely. we will see you if you fall into that limited life prognosis. You can come see us. Because there's a lot of cancer patients, and I'm thinking of one particular lady who has really bad endometrial cancer, and she has a lot of symptoms, and she would absolutely qualify for hospice, but when I saw her last week, she goes, I'm not sick enough for hospice. I'm not ready for hospice. Now, she stopped all her therapy because she has run out of therapy. But she said, nope, no hospice yet. I'm just going to keep coming to you guys. So yes, see anybody.
Incredible clinic. So we had another question come in, and it talks about for those types of patients, perhaps that are going to have multiple visits to your clinic. Are there places in Santa Fe to stay overnight for reduced rates?
I'll let Amy handle that, because I think there are. She knows more than me.
So I'm also a social worker. You remember he said he refers all those.
Yes, that's right. Social worker
services.
problem.
Yeah, right. So yes, we do have, the hospital has done a great job of getting discounts with some of our local hotels. So we do have a list. We also are in the same parking lot as Santa Fe Suites, which is like an extended stay hotel where a lot of our patients that come for cancer treatment from Taos or further away that don't want to have to drive back and forth or are advised not to drive, stay there and just walk across the parking lot. So they're within, 30 feet of our clinic.
Yeah. They're
and
not bad. I've been in one. They're
They
good.
give a discounted rate as well. So, and we also help them find other resources or grants if it is a financial barrier so that they can stay.
How many a month? Both sides, in and outpatient? Well, Amy just ran a report and presented at the meeting. We saw 300 this year so far. Now, I will tell you that we are seeing more patients than the UCSF palliative team. And their hospital is just a tad bigger than us. So we're doing all right. But we want more. We are greedy. We're all about more. So we want to get ourselves in the renal clinic and in the pulmonary clinic and the primary. We just want them to know we're here, first of all. I mean, I couldn't even believe that the clinic on the other side of town didn't even know we're there. But we saw 300, so 100 a month, I guess. So we'll probably do around 900 to 1,200 if that keeps up. So that's more than UCSF saw 700 last year. So we're all right. We're doing okay.
That was,
I don't even know the numbers of the clinic. I know I'm busy all day. So
my question was related to that in that you said you were the only palliative care physician in Santa Fe, and then you had 2 hospice.
well, there are
physicians.
there are 4 doctors that are boarded in palliative care, and I'm the only one doing palliative care. 2 of them are doing hospice and something else. So they are like the medical directors for some of the 6 hospices there in Santa Fe. And then 1 is doing nothing with her board certification. So
I just wonder how you can spend 90 minutes with a patient and still want more patients.
because I'm greedy.
But that doesn't
glutton.
make sense.
Well,
I
it
mean,
doesn't make sense, but we do what we think we need to do for the patient.
That's
Now, I'm not
wonderful.
saying every visit's 90, but that patient needed 90. And so, and it was the first time, and he was suffering, and that's what it took. Now, was I in there the whole 90? I was in there for about 75 of it, but our nurse was in there for the whole 90. So sometimes we're tag teaming, so I'm going in for 45, Amy's going in for 30, nurse going in, and then the patients, they're fried after about an hour and a half. That's it. They're done. So 90 is probably the top end. We've had a couple, but we're greedy, and we'll get more people if we get too busy.
Is there any other questions? You guys did a great job. You guys did great.
Have a great night. Thanks for coming.